Hey everybody, welcome back to Girl Talk. Thank you so much for joining me. As always, before we get started, if you could give me a like, share, a thumbs up, comment, and hit that subscribe button, I would appreciate it. So today we're actually going to do things a little bit different on the Lindsay Clancy trial. Um, there was a lot of testimony yesterday, but the ones that we want to listen to are the emergency room doctor and also the psychiatrist. The psychiatrist was really, really good. Um, I don't know. I'm not sure how that's going to go as far as the testimony and which side that she was on, because it really could go either way here, guys. It's just crazy. Um, but we're just going to do kind of like a real quick roundabout, because it's about 7 hours long. So, but I definitely want to get those two uploaded for you today. So we're going to get actually right into that. And here we go. And if you didn't see it, we have a new thumbnail. I'm so excited. I'll get into that story another day. Um, Technology is no longer my thing, but we will talk about that. But let's get into the trial. Here we go.
Good afternoon. Can you please state and spell your name for the record? Sure. My first name is Sejal, Sejal. Last name is Shah, Shah. What's your date of birth? 5/8/81. What do you do for a living? I'm a psychiatrist. And can you briefly describe your education and training background that qualifies you to be a psychiatrist? Yeah, absolutely. So I did my undergraduate in Philadelphia at the University of Pennsylvania, followed by medical school at Jefferson Medical College, also in Philadelphia. I moved. Oh, sure. I moved up to Boston to do my residency in psychiatry at Brigham and Women's Hospital and Beth Israel Deaconess, followed by a fellowship in consultation liaison psychiatry at Brigham and Women's Hospital, and then stayed on as a faculty member. And where do you work currently? I work at Brigham and Women's Hospital. And what is your role there? I'm Associate Chief of the Division of Psychiatry and Medicine, leading the Consultation Liaison Psychiatry Service at Brigham. And what is the consultation and liaison service? Yeah, so consultation liaison psychiatry is a subspecialty of psychiatry that works at the interface of psychiatry and medicine. So we work both in the inpatient and outpatient settings. In this particular instance, we get called by other healthcare providers that may need help with their patients or have a question related in the psychiatric realm. And so I would see a patient that's admitted to the hospital and help provide recommendations to the physicians and the rest of the care team that's caring for that patient. So basically, say at the Brigham, if a patient's being treated there and a medical doctor is treating them and thinks that they need a consultation with the psychiatrist, your department would be called. That's correct. Okay. And how long have you been with the Brigham? 19 years. Now, I want to direct your attention to January of 2023. Did you interact with a patient named Lindsay Clancy? I did. And was that on January 29th, 2023? Yes, that was the first of a handful of times that I saw her. And why did you meet with Lindsay Clancy on January 29th, 2023? So my team was seeing Ms. Clancy for a number of reasons, including for psychiatric safety risk assessment. She had come in reporting a suicide attempt, which is a common reason why my team would be called, is to continue to ensure that patients are safe when they're in the hospital. So we make recommendations about kind of safety status, what can we do to help keep a patient safe, but then we also make recommendations related to medications. So that's why my team was following her. So that was one of the reasons why I saw her on the 29th, is to continue that assessment. I was also called to ask I was asked a new question that day, a consult question on whether she was able to make the decision to change her healthcare proxy from her, at the time, husband to her parents. And when you consult to help determine whether someone's capable of making a decision like that, changing their healthcare proxy. Are you evaluating their medical decision-making capacity? That's correct. Okay. How do you go about doing that? So there's generally 4 parts to medical decision-making capacity. The first is whether somebody's able to voice a choice and whether that choice is consistent over time. The second is whether they understand the situation under which they're making that choice. The third part is appreciation of the risks and benefits. And the fourth part is kind of being able to reason or rationalize that information to be able to come to a choice and how they came to that choice. Now, if you're doing this evaluation to determine someone's capacity to make decisions, would a traumatic brain injury factor into that evaluation? It could. When you evaluated Lindsay Clancy, was she able to voice a choice to you about who she wanted to be her healthcare proxy? Yes. And is she speaking to you or writing this down? She's speaking. So she's already been extubated at that point? That's correct. And she's speaking to you, and were you aware that Patrick Clancy was her healthcare proxy? I was told that by her primary medical team. Okay. And when you talked to Ms. Clancy, did she tell you who she wanted to take over that role? She did. And who was that? Both her parents. And you talked about that needing to be a consistent choice. How did you ensure that was a consistent choice with her? Yeah, so we waited to make the change from Patrick Clancy to her parents until the next day for a variety of reasons. We wanted to ensure that that choice was consistent over time, and especially because the day that I saw her, she had just gone through some pretty major medical events, including she had a major spine surgery, a decompression and a fusion. She had gone through some oxygen desaturation overnight, so was not breathing as well. Her heart rate was up, all of which then led to her being what we call delirious. She was confused overnight to the point where she asked her nurse, "Am I delirious?" And she was also experiencing some visual hallucinations. So that was one of the reasons why I was called in, to make sure that she was able to make that decision to change her healthcare proxy. And then in addition, the team had also voiced, concerns that she had come in after a reported suicide attempt. And so making sure that she was able to make that decision of sound mind. And so we actually waited until the next day when she could be reassessed. At that point, her delirium had cleared, and she was continuing to make that consistent choice to change her healthcare proxy to her parents. And in fact, you noted in the medical records that the hallucinations were part of an issue with oxygen. It could be. That could be one of the reasons. Delirium is usually due to a variety of different medical reasons, and oxygen desaturation could be one of them. She had also just recently had anesthesia related to a surgery that she had on her spine, so that could be another reason. And then her heart rate was also actually quite elevated, so that could be another reason. Is it common for patients who are just coming off of anesthesia from surgery, who have an issue with oxygen and other medical issues that you described, to have visual hallucinations? They can. It's not that everybody does, but they can. And delirium can be quite common after surgery, and particularly anesthesia. And those hallucinations that she was having, those were resolved by the next day. They were over by the next day, correct? That's correct. And her choice to change her healthcare proxy to her parents was consistent the following day, correct? That's right. You also talked about the patient has to understand the risks and benefits of the decision, correct? That's correct. How do you make sure the patient understands that? Yeah, so one of the things we do is really ask patients to take us through their thought process of why they're making that decision and what led to them making that decision at that moment in time. So we're able to kind of see their thought process and ensure that they're understanding, what it means to remove one person and add another. And what was Ms. Clancy's thought process in explaining that to you? Yeah, she was saying that her parents are quite supportive to her, and that she was thinking that she would have to change her healthcare proxy from her husband to somebody else. And we didn't necessarily go into the reasons as to, why she would have to change it, but she explained that she was very close with her parents. They would see each other frequently, given that they lived in close geographic proximity, and that she felt that they were very supportive to her and would have her best interests in mind should we need to invoke the healthcare proxy, or that if she couldn't make her own medical decisions.
So was there a concern on her part that her husband wouldn't have her best interests in mind at that point in time?
Sustained.
You also talked about the patient. You have to make sure the patient's thinking about the information rationally. How do you go about doing that?
Yeah, so one of the things we do is really ensure that the patient understands the situation and all of the kind of parts around it. So this comes into play much more when it's about a specific medical intervention, like an invasive medical procedure, or something like an amputation or a surgery. With a healthcare proxy, one of the things you want to make sure is that the person that they want to change their healthcare proxy to or appoint as their healthcare proxy makes sense in the context of their life. Ms. Clancy was able to talk about how her parents were quite involved in her life. And so that's one of the things that we would assess.
And then the last thing was making sure the patient understands the risk if the change doesn't happen. Mm-hmm. Did you go over that with Ms. Clancy, and how did you do that?
Yeah, I did go over that with her. We talked a little bit about how it could mean that she would not have a healthcare proxy were she not to appoint her parents. And so we went through that, it's always in healthcare, we always talk about how it's great to have a healthcare proxy just in case you become unable to make medical decisions, and who would you want that to be?
And during this conversation with the defendant going over all these points, did you ever have difficulty understanding her?
I did not.
Did she ever appear to have difficulty understanding you?
So the first day when I saw her on January 29th, she described herself as feeling confused, and I definitely witnessed that as well. We went through a bedside cognitive evaluation, and she definitely made some mistakes on some of the cognitive evaluation. Therefore, I did diagnose her at that time with delirium.
And then she was re-evaluated the following day, and there were no issues with her understanding, and the delirium was gone, correct?
That's correct.
And were you aware during this evaluation that Ms. Clancy did not have a brain injury?
I'm sorry, can you repeat the question?
Were you aware that Ms. Clancy did not have a brain injury at that time?
One of the things that we look at is any kind of relevant medical information that might be available to us. And I noticed that her Glasgow Coma Scale, when she was transferred to Brigham and Women's Hospital, was a 10, which would indicate that she could potentially have had a moderate brain injury. But I don't recall thinking about specifically whether she had a brain injury.
Were you aware that a CAT scan was done, page 110 of the records, and on the CAT scan, the impression was no acute intracranial findings, so no brain injury.
So you can.
CAT scan.
I did review the head imaging that was available at the time. You can have a normal CAT scan and still have a brain injury.
Were you aware that she had multiple CAT scans that showed no bleeding in the brain, no skull fractures, no injuries, just visible injuries whatsoever?
I'm sorry, but can you repeat the question?
Were you aware that she had multiple CAT scans at South Shore Hospital and at Brigham and Women's that showed no skull fractures, no intracranial bleeding, no hemorrhaging, no visible damage whatsoever?
Yes.
And were you aware that she was evaluated at South Shore Hospital and at the Brigham, and she had no external injuries on her head either?
Yes.
Now, she was allowed to change her healthcare proxy to her parents, correct?
That's correct.
So if someone was had an injury, a brain injury, to the point where they didn't know what was going on, or they were having trouble processing or thinking, they wouldn't be allowed to change their healthcare proxy, correct?
It depends to what extent. Most patients that have either a head injury or severe mental illness, let's say, just anything going on with the brain, retain the ability to make most medical decisions. And we think about changing healthcare proxies as a pretty low-risk decision. As I mentioned before, something like an amputation or a major surgery, invasive procedure is something that we would hold somebody to a higher bar. But a healthcare proxy is a pretty low risk, especially if it makes sense in terms of who they want to change it to.
And when was her Glasgow score 10?
I believe it was as she was being transferred from the outside hospital to Brigham and Women's.
And you're seeing her several days later, correct?
Correct.
And so when she was transferred from the outside hospital to Brigham, she was unconscious, correct?
I believe so.
Okay. So now she's conscious, correct?
That's correct.
And when she was transferred from the outside hospital to Brigham, she wasn't communicating or speaking or opening her eyes on her own, correct?
That's what the report said. I was not there at that time, but the notes that I read, that's correct.
So when you're speaking to her a couple days later, she's opening her eyes, she's communicating, she's responsive, she's interacting, correct?
Yes.
So it's fair to say that her Glasgow score would be higher than the 10 when you were speaking to her, correct?
Yes.
Now, you did a mental status examination of her while you were doing this evaluation about her decision-making capacity, correct?
Yes.
And it's fair to say under mood you listed okay,
Yes.
that you listed her thought process as organized, goal-directed. Is that correct?
Yes.
You asked her if she was having hallucinations or delusions, and she, other than those initial ones the first day, she denied those.
During my evaluation, yes.
And she also denied suicidal intent and homicidal intent, correct?
Yes.
And you listed her insight and judgment as fair, correct?
Yes.
Her behavior was calm and cooperative.
Yes.
And you didn't see anything about her behavior that would indicate to you that she was responding to some type of voices or hallucination that you couldn't see.
At that moment, no. But as I mentioned, I did speak with the nurse beforehand, and Ms. Clancy was able to report to me that she reported visual hallucinations overnight.
Overnight after surgery.
That's right.
And then never again.
Not during my evaluation.
And did you speak to Ms. Clancy again on February 19th, 2023?
Yes.
And was the purpose for that to prepare her for a transition from Brigham and Women's to Spalding Rehabilitation?
That was one of the reasons.
And what were the other reasons?
So it was an ongoing safety evaluation, ongoing evaluation of psychiatric safety risk, as well as medication evaluation to determine if her medications were at the right level, the right dosage, and that she was on the right medications, and then just ongoing evaluation in terms of kind of her mental status.
And during that meeting, she denied suicidal intent, correct?
That's correct.
She denied homicidal intent, correct? She denied having auditory or visual hallucinations, correct?
Yes.
She reported her mood as okay, is that correct?
Yes.
And she told you she was looking forward to moving to Spalding, correct?
Yes.
She also denied any confusion or disorientation, is that correct?
Yes.
And again, you described her mood as okay on that day?
Yes.
And you described her as future-oriented on that day?
Yes.
And then you spoke to her again on February 21st, 2023, is that correct?
Yes.
And on that day, is this the same purpose that you just described, getting her ready, assessing her mental status and getting her ready to transfer to Spalding?
Yes.
Okay. And during that time, you wrote that the patient reported feeling down about her current situation, her paralysis, and the events leading up to her hospitalization. Is that correct?
Yes.
And you also noted that she said her thoughts about what she had done were not constant throughout the day, correct?
Correct.
So she wasn't thinking about killing her children throughout the day, every day, correct?
Correct.
And she said she had no suicidal intent, no homicidal intent, correct?
Correct.
No auditory or visual hallucinations, correct?
Correct.
You also write no PI. What does PI stand for?
Paranoid ideation.
And there was none of that either.
Correct.
You also made a note, notes low mood today in the context of her physical and legal situation, but does not currently meet criteria for major depressive episode. Is that correct?
Yes.
So her focus seemed to be on her physical and legal situation, but being hopeful about moving on to Spalding.
Can I see counsel?
Right now they're at sidebar. I did forward it a little bit, and it will be on shortly.
And so her focus at that time appeared to be her physical situation, her legal situation, and looking forward to going to Spalding Rehab.
Yes.
And then your last visit with her was February 22nd, 2023, correct?
Yes.
And again, she indicated she was hopeful about treatment at Spalding.
Yes.
She was future oriented.
Yes.
And she denied suicidal ideation, homicidal ideation.
Yes.
She denied audio hallucination, visual hallucination, and anything else of that nature.
Yes.
Thank you.
Tree Ranks. So, Doctor, from your testimony, and correct me if I'm wrong, was she, to your opinion, in your experience, an honest patient telling you what her symptoms were, if any?
Objection.
That's an evaluation in the psychiatric.
I'll allow that question.
Yes.
In other words, she didn't go off and try to exaggerate to you and say, I'm seeing visions and I'm hearing voices and I'm suicidally ideated and I'm homicidally ideated. She didn't say any of those things to you, did she?
No.
She actually denied them, right?
Correct.
So this is not, in your opinion, someone who was trying to exaggerate her conditions for some legal reason, correct?
No.
And you obviously were in close contact with her for about a month, right?
That's right.
Just a couple of questions. Counsel asked you whether or not, and I think it may have been in the beginning in January, that you had difficulty understanding her. Obviously, after removing the tubes and everything else, you're able to talk with her, correct?
Correct.
And you knew that one of the concerns, if you will, was postpartum issues. You knew that, right?
Yes.
And in your experience as a psychiatrist, you're familiar with the concept of postpartum psychosis, correct?
Yes.
And you know that people can communicate and plan and act on plans, even if they're in the middle of a psychosis, right?
Yes.
You don't have to be drooling and stumbling and unable to walk and talk to be in a psychosis, do you?
No.
So in other words, a person can be in a psychosis and can communicate to friends, family, people, talk, correct? So you didn't, as counsel asked, you didn't have any difficulty understanding her. She wasn't slurring her words or anything like that when she was able to talk.
Right.
Okay. One of the things that when she was admitted, and then without going through, I'm not going to go through all the stuff we've already talked about with the medical condition and everything else. You indicated that she was very, very ill, correct?
Correct.
Did she appear to be cooperative to you when you would interact with her?
Yes.
As a doctor, as a psychiatrist, you're familiar with bipolar, the concept of a bipolar diagnosis, correct?
Correct.
Can you tell me what bipolar means?
Yeah, so bipolar disorder is a mood disorder, categorized as a mood disorder, where patients have distinct depressive episodes, as well as, depending on the type of bipolar disorder, either hypomanic episodes or manic episodes, to the point where they don't sleep for days, they still have lots of energy, there's this decreased need for sleep, there can be irritability, there can be impulsiveness, racing thoughts. A lot of patients describe that they're out of control of their behavior, and then severe episodes can also include psychosis.
And in reference to bipolar, as you were referring to, when somebody is hypomanic, what does hypomanic mean?
Yeah, it's a lesser degree of mania. So when patients are hypomanic, they don't always experience things like psychosis, but they might experience some of the other symptoms that I described, including racing thoughts, kind of moving too quickly, talking too quickly, being irritable.
And as it relates to the hypomania, would that include things such as somebody who is getting up early in the morning and exercising, or cleaning out their house, or selling their property out of a garage and having difficulty sleeping and they're awake all night?
Yes.
as a psychiatrist, one of the things you were concerned about when you were first started to deal with her, as well as when you were releasing her, if you will, is the medication that she had on board, so to speak, when she came into the hospital, right?
Yes.
Do you remember, and I know it's difficult to recall offhand, but do you recall the medications that she was actually under from purposes of taking her blood when it was tested?
When she first came to the hospital?
Yeah, if you know.
I believe her medication list for previous to the incident, she was on amitriptyline, diazepam. I believe she was also on prescribed lorazepam, and there may have been one other.
Okay, so looking at that, if I tell you that there was a toxicology report done on her as of January 24th by way of taking her blood. You're familiar with that, right? When they analyze for toxicology. And toxicology obviously would tell us what the medications, if any, what type of drugs she had on board, booze, cocaine, anything, right?
Yes.
And you're aware that the toxicology report, as well as the report from the Department of State Police, as well as the NMS laboratory, which would be in Pennsylvania. So that's an international or a national respected laboratory, isn't it? The NMS lab, if you know?
I don't know.
Okay. But you know that they did take her blood, they did test her blood, and it was at the state police laboratory as well as any other labs that tested it, right?
Yes, I believe I found that out later. I did not know that the first time I saw her because those labs take a little bit of time to
Sure,
connect.
and you treated her for about a month, so you were pretty
That's
close
right.
to her and got to know her quite well.
Yes.
Would you agree with me that one of the things that her blood reflected or that she was on was trazodone?
Yes.
And can you tell me what trazodone is?
Yeah, trazodone is an antidepressant medication. It's more often utilized as a sleep aid because of one of the side effects is sedation. And so patients that are often having difficulty sleeping are placed on trazodone.
And is trazodone, does that share some of the qualities of what are referred to as SSRIs, even though it's not an SSRI, it shares similar qualities?
Yes.
Can you tell me what SSRI means?
Yeah, so it's a selective serotonin reuptake inhibitor, and it's a class of medications that are antidepressants.
And the SSRIs, that would also include Zoloft, for example?
Correct.
Would also include Prozac, for example?
Yes.
Are you, as a psychiatrist, aware that Zoloft and or SSRI Prozac should not be prescribed to a patient who has bipolar?
Yeah, it can be prescribed. Oftentimes it's prescribed together with another medication that can be protective because patients with bipolar disorder may be experiencing depression. And so they may be prescribed an antidepressant, but along with another medication that what we call protective.
And in reference to the SSRIs, the selective serotonin reuptake inhibitor, what does that mean? Selective serotonin reuptake inhibitor, what does that mean?
Yeah, so oftentimes in depression, patients are kind of lacking serotonin in the spaces in their brain that helps.
Can I interrupt you? What is serotonin?
Yeah, serotonin is a neurotransmitter, so it's a hormone in the brain that works on the brain. It works in other areas in the body as well, but for these purposes, it works in the brain at nerve endings throughout the body. And that neurotransmitter helps with things like mood regulation. For patients with depression, they're often lacking kind of that ability to have enough serotonin in those spaces. And so a selective serotonin reuptake inhibitor prevents serotonin being kind of sucked back into the cell. So it allows for serotonin to be more available.
And what is an SSAI? What does that mean? Antagonist, selective serotonin antagonist.
So those are medications that kind of do the opposite.
Okay. And you knew, as a psychiatrist, at least looking at her history, you knew that she had been seeing psychiatrists immediately prior to her suicide attempt, correct?
Correct.
And you knew that she had been prescribed a number of drugs by these various psychiatrists, correct?
Correct.
And to your knowledge, was she prescribed diazepam?
Yes.
Valium? Was she prescribed buspirone, otherwise known as Vanspar?
Yes.
About Wellbutrin?
Yes.
And what is Wellbutrin? Is that an antidepressant?
It is an antidepressant.
Hydroxyzine. What is hydroxyzine?
It can be used for a number of reasons, but for psychiatric purposes, it's often used as an anti-anxiety medication.
And Klonopin.
Yes.
Is hydroxyzine, is that a, strike that. Klonopin, that's a benzodiazepam, right?
That's correct.
And then lamotrigine.
Yep, lamotrigine.
Lamotrigine, sorry.
Yes.
What type of medication is that? Is that a mood stabilizer?
It is, yeah. It's also an anti-seizure medication, but in the psychiatric realm, it's used as a mood stabilizer.
And then we talked about Prozac, that's an SSRI, correct?
Correct.
And what's Remeron?
Also an antidepressant.
So in addition to all of the drugs that I had mentioned, she was also prescribed Remeron, correct?
Correct.
She was also prescribed Seroquel or quetiapine.
Yeah, quetiapine, yes.
Quetiapine, okay. And what is Seroquel?
So Seroquel is an antipsychotic medication.
And she was prescribed, as we already talked, trazodone. She also prescribed amitriptyline.
Yes.
What is amitriptyline?
Amitriptyline is one of the older antidepressants. It's a tricyclic antidepressant that can often be used to help with sleep, but also mood.
And Ambien, correct?
Correct.
And Zolpidem.
Yeah, Zolpidem is the generic name of Ambien.
Oh, okay. Some of these drugs, they also have what's called a suicide warning or a black box warning. Isn't that right?
Yes.
Can you tell me what that means?
Yeah. So in studies that have been done, some of them show that especially after starting an antidepressant, it can increase someone's risk of suicidality. Many of those studies showed that it was mostly in adolescents and young adults, but it can happen in adults as well.
And Celexa is also a drug. Is that an SSRI too?
It is.
And all of these drugs that we just went through were all prescribed from end of September till January.
Yes, September 2022.
4-month period.
Yes.
It's an awful lot of drugs to be prescribed in 4 months, isn't it?
Sustained.
Thank you.
Thank you.
Almost redirect?
Yes. Doctor, all those drugs that defense counsel just listed, you're aware she wasn't on all of those drugs at the same time, correct?
Correct.
And did you know that many of those drugs she took a very small amount of? Some she didn't take any pills at all.
I was not aware of that.
For Buspar, which is one of the ones he mentioned, were you aware the first prescription she only took 2 pills out of that bottle?
I was not aware.
Were you aware the second prescription a month or so later for Buspar she took 0 pills out of that bottle?
I was not aware.
So where are you getting this information about what she was on and when?
Yeah, so one of the things that we do is try to collect as much information as we can during our assessments. And so we look through the record in terms of what was prescribed. We also talk with other providers as to what they prescribe. But in the context of the assessments that we were doing, it did not require us to determine, what exactly she had been on before, because we were using a different set of medications to treat something, different symptoms that she was experiencing.
So you really have no idea what she was taking or when. You just know what was prescribed.
I know what was prescribed, and then we were also getting reports of what was being taken, what wasn't being taken. But
From the defendant?
Correct.
Okay. So she's reporting to you that she took those medications, but you'd be surprised to know that at least one of them, 0 pills were taken.
I don't think I'm surprised. No.
And you talked about prescription and what she was taking. Were you aware that in the time frame just prior to her being admitted to the hospital, she was only prescribed trazodone, Valium, and amitriptyline, just 3 medications?
Yes, I was aware.
And you were asked about mania and exercising and cleaning out your garage and selling your belongings could be signs of mania, correct?
Correct.
But there are people who just exercise every day and they're not manic, correct?
Correct.
And there are people who have a messy garage and have accumulated a lot of junk and decide to clean out the garage that aren't manic, correct?
Correct.
And in fact, if someone is manic and attempts to do one of those tasks like cleaning out a garage, it's usually in a disorganized way, and oftentimes they don't finish the task, correct?
Sometimes.
So if someone approaches a task like cleaning out the garage by organizing with another party, organizing the belongings, separating them into keep, sell, throw out, but that's pretty organized behavior, correct?
Correct.
And if someone sells belongings that they no longer need, that's not necessarily a sign of mania, correct?
Correct.
That's more if they're selling their stove and then they have nothing to cook with, correct?
Correct.
So if they're selling junk in their garage that they no longer need, that's not necessarily manic, correct?
Not necessarily.
Thank you.
Mr. Rankin?
So if the person, as counsel said, they're exercising every day and they have a messy garage, that obviously would not be indicative of hypermania.
Probably
A
not.
normal person could have, as counsel said it. How about a person that at the same time can't sleep because the insomnia is so bad they go 48 hours without sleep? Is that something to be considered in the whole evaluation?
Yes.
How about the fact that the person saying that my brain is broken and that they can't concentrate, they can't think? Is that something that the person you would consider in conjunction with the messy garage and the exercise?
Yes.
Thoughts of hurting themselves, suicidal ideation, that's something that's important to evaluate?
Yes.
Homicidal ideation, telling your husband that you're having thoughts about hurting your children, that's something you consider, isn't it?
Yes.
In reference to counsel's comment about just 3 medications that she was on prior to trying to commit suicide, you're not aware of the doctors telling her to discontinue this medication, start a new medication, go on to a different medication, depending on the doctor. You're not aware of that, right?
No.
And finally, if you know, did she sign a DNR, do not resuscitate?
She asked to the day after the first evaluation that I did of her, which was the capacity assessment to change her healthcare proxy. But in the context of her reporting a serious suicide attempt, we did not change her code status. We continued to chat with her about that, and she ultimately came to the conclusion that it made sense to make sure that her mental health was stable before she considered her code status.
Okay, but her initial reaction or her conversations with you all was that she wanted to have a do not resuscitate status.
Correct.
Thank you.
All right, thank you, Doctor.
Thank you.
Okay, so this is the next one, and I believe this is an ER doctor. So we're going to listen to this one.
Is your first and last name?
Kelly McDonough,
Can you spell your last name for the record?
McDonough.
And what do you do for a living?
I'm an emergency medicine physician.
And how long have you been a physician?
11 years.
Can you tell us a little bit about your educational background?
I went to medical school at the University of New England in Maine. I did my residency at Kent Hospital in Rhode Island. I subsequently worked at Kearney Hospital in Dorchester, and I've been at South Shore Hospital since 2021.
And in what, are you primarily in the emergency department at South Shore Hospital?
Correct.
Have you been in any other department at South Shore Hospital?
No.
Are you licensed to practice in Massachusetts?
Yes.
I'm going to draw your attention to January 24th of 2023. Were you working in the emergency department that evening?
I was.
At some point, were you advised that a patient was being brought into your emergency department?
I was.
And were you aware of that patient being Lindsay Clancy with a date of birth of 8/11/90?
Yes.
And what kind of information were you given upon learning that the patient was coming here? What were you expecting to receive?
I was expecting a trauma 1 response. A patient who had fallen out of a window from a height and didn't know much more than that.
Okay, and so when you say trauma 1, what does that mean for you?
So we had 2 designations for trauma responses, a trauma 1 and a trauma 2, and there's certain criteria for each. And there's a long list of criteria that are determined by the resource nurse who receives the EMS call.
Okay, and so when we say 1 and 2, which is more serious than the other?
Trauma 1.
And so what do you do to prepare when a patient is coming in and you know coming in that it's likely a trauma 1 situation?
So we gather in the trauma room and make sure that we have all available staff needed to take care of the patient.
And what kind of staff are with you in the room, in the trauma room?
So for a trauma 1 response, it would be the emergency medicine physician, it would be anesthesia, the trauma surgeons, sometimes neurosurgery will be there.
And fair to say you also have a whole host of other staff, including nurses, emergency room techs. All of those people are also available to assist if you need it.
Correct.
Now, when this individual came in, when Lindsay Clancy came into the emergency department, were you aware from EMS that she had already come in with some sort of neurological deficits?
I think that from my best recollection, we knew that she was unresponsive, found down outside of her home.
Were you advised that it appeared she might have a spinal injury?
Yes.
And that she was not she may have been moving her arms and her head, but not her legs.
Correct.
Now, when the team was assessing her in the emergency department, what types of steps do you take to perform that assessment of the patient?
So there's a series of steps that we go through to assess a trauma patient that are followed every single time. ABCs, airway, breathing, circulation, and then we do a secondary survey.
Okay. And in this circumstance, was the patient breathing?
Yes.
And when she came into the emergency department, was she breathing on her own or intubated?
She's breathing on her own.
At some point, did the ER staff have to intubate her?
Yes.
And why was that?
For airway protection, there was a concern that maybe she would have a head injury and she would decompensate later. And so to protect her airway, she was intubated.
Now, is that a standard protocol when there's concern for head injury?
Yes.
Did you see any obvious signs of a head injury when she arrived into the emergency department?
No.
What kinds of things would you see if somebody had an obvious head injury?
You might see bleeding or lacerations or abrasions.
Now, did you observe any other obvious injuries to this patient?
I did. She had some superficial lacerations of her neck and wrists bilaterally.
Do you recall if she came in on a backboard with a C-collar?
She did.
And do you remove the C-collar at some point to assess the patient for injuries?
We didn't completely remove it temporarily to visualize and feel her neck and then put it right back on.
Okay, and you said you did observe some injuries to her neck, correct?
Yes.
I'm just going to show you some photos that have been marked. That's okay, on the screen next to you. This has been marked as exhibit number 111. Is that an accurate representation of the neck injuries you observed?
Yes.
You also indicated that she had some other injuries to her wrists.
Yes.
And I'm just going to show you 112. Is that accurate as to the injuries to the wrist you observed?
Yes.
Now, you described the injuries as superficial. The injury that's kind of in the middle of the photograph there, can you describe what part of the body that injury is?
You're describing the one that's sort of open?
Yes.
Yeah, so that's the anterior aspect of her wrist.
And were you able to examine that injury?
Not in detail.
Okay. Was it something in your emergency, your assessment of the trauma one situation, was that something acute that you had to address?
No.
And is it fair to say that that injury goes through kind of the subcutaneous tissue of the skin?
Yes.
Did you observe any injuries to an artery or a vein or anything in that area?
I did not.
And then just showing you exhibit 113, which is the other wrist. Same thing. Did you observe anything in your assessment, your trauma one assessments, to say whether these were acute at the time?
I assume that they're acute.
Okay, but as far as treatment of them, did they require you to immediately address it?
No.
To manage blood flow?
No.
What was the more serious, or what was the focus of your assessment of her in the emergency department?
I think the main concern was for a head injury and or a spinal cord injury.
And you said that as part of the assessment team, you had a neurosurgeon available as well as a trauma surgeon, correct?
There was no neurosurgeon there that day.
Okay. Was there a trauma surgeon?
There was.
Who was that?
Dr. Christina Carpio.
Did you order any series of tests in order to help you assess the nature of whether there was any head injury or what the extent of the spinal injury could have been?
Yes.
What kinds of tests did you order?
CAT scans.
As part of the emergency room protocol, do you also draw blood for patients that come in?
Yes.
And how is that usually done?
It's usually done on arrival by the nursing staff.
And do they draw blood according to a physician's orders, or do they draw blood for various purposes. Explain to us how that works.
So it's usually like what we call a rainbow. So they just draw all the tubes of blood as soon as the patient arrives in anticipation for orders.
Okay. And so what happens to the blood after somebody in the emergency department takes it from the patient? Where does it go?
It gets tubed to the lab.
And fair to say that at South Shore Hospital, they have a pneumatic tube system, correct?
Correct.
And that it goes to a separate laboratory.
Correct.
And once a physician then assesses a patient and determines what kinds of testing needs to be done on those samples, how do you communicate that to the laboratory?
So orders are put into a computer and they go through the computer to the lab.
And as you're treating a patient, is it oftentimes necessary to change the orders or order additional tests?
Yes.
And so in this particular case, blood and urine was collected from Lindsay Clancy upon her arrival, correct?
Correct.
And then sent to the lab.
Yes.
Now, going back to the imaging tests, you said that there were some CT scans that were ordered.
Correct.
What areas of the body were the CT scans for?
It was her entire body, her head, her neck, her chest, her abdomen, and her pelvis.
Now, as far as the CTs for her head, were there more than one CT test for the head?
I don't remember. I'd have to look at my record.
Well, what are the normal, or what are the options for CT head scans?
It's usually just a CT head plane, but you could also do a CT angiogram, depending on your concern for injury.
And do you recall which one you ordered here?
For a trauma one, it would be a plain CT head.
And why do you order that particular test?
Well, we're trying to assess for skull fractures, intracranial bleeding, things like that.
And when you say a plain CT, what's the exact order that's put in for that type of a CT?
CT head.
Okay, and are there CT heads with contrast?
There are.
And are there CT head scans without contrast?
Yes.
May I approach the witness? I'm gonna show you this documents, if that's okay.
Sure.
I apologize. There's a series of pagination, so I'm just going to draw your attention to this page is black. If you can just take a look at it. Sure. Okay, and I'm just going to flip to the next page as well. The next page is blank, but is this the extent of what you would have received as far as information regarding a head CT that was done without contrast?
Yes.
And I'm going to just draw your attention again to another fact page here towards the end. It's actually 2 pages from the end of the document, if you could take a look at that. And does that reflect the report you would have received for the head CT ordered with contrast?
Yes.
And in addition to getting a report from imaging, you also receive some actual images, correct?
Yes.
And do you review those?
Yes.
In this particular circumstance, when it came to the patient of Lindsay Clancy, was there anything remarkable in either of those head CTs?
Not that I recall.
And in fact, the head CT with contrast indicated the impression was unremarkable. CTAF had no evidence intracranial aneurysm, arteriovenous malformation, or abrupt occlusion, correct?
Correct.
What does that mean?
It essentially means it's a normal study.
Now, as far as the other CT scans that were conducted, there were findings, remarkable findings on some of the others, correct?
Correct.
And what did they reflect in your experience as far as her injury goes?
From what I can recall, I know she had a thoracic spine injury.
And how about the CT that was done of the chest area?
I don't recall.
I may approach. Does that refresh your memory?
Yes.
And what was based on the result of the chest CT?
So it talks about her thoracic spine injuries.
Now, after reviewing all of the images, all of the CT scans that were done here, the cervical spine, the head CTs, the thoracic spine, what was the plan for this particular patient? Was she able to be treated further at South Shore Hospital?
The decision was made by the team that her injuries were too severe to stay at South Shore Hospital, and the decision was made to transfer her to a tertiary care center.
Were you able to stabilize her before transporting?
Yes.
Is that something that's important to make sure our patient is stable before sending him off in the ambulance or a helicopter?
Yes.
And so as far as this particular patient goes, are you aware of whether any surgical intervention had to be done before she was stabilized and transported?
I was not aware of any intervention being done.
And again, you had Dr. Carpio, who was also there to assess that.
Correct. We work as a team.
Kind of going back to those injuries on her neck and her wrist very briefly. Can you explain to us the difference between bleeding in maybe an artery or a vein and how that might present itself in an emergency situation?
Venous bleed would be a little bit slower, darker blood, and arterial bleed would be pulsatile and bright red.
And is it fair to say that when you strike either an artery or a vein that they're of different pressure systems, and so the manner in which the blood comes out is different?
Yes.
In either circumstance where an artery or a vein is struck or nicked or cut, would that be something that you'd have to stabilize for a patient in order to make sure that they don't bleed out?
Yes.
Was that done here?
It wasn't necessary.
Now, this particular patient at some point was noted to be, I think it was referred to as hypothermic. Do you recall that?
Yes.
Do you recall at what point in your treatment of her was that noted? Was it as she was coming into the emergency department, or did that develop while she was in the emergency department?
I don't recall.
What was the course of treatment for a low body temperature?
We placed something called a bear hugger on them, which is a warming blanket.
And can you explain to us what could cause a person's body temperature to drop to, I think it was 82.1?
There are many reasons, but it could be a metabolic disarray or exposure.
In this circumstance, did you know what the source of the drop in the body temperature was for Ms. Clancy?
No.
And do you recall how long she was in the emergency department before she was transported approximately to the Brigham?
I think it was about 4 hours.
At this time, Your Honor, I would move to enter into evidence a copy of the South Shore Hospital medical records for Lindsay Clancy from January 24th, 23 as the next exhibit.
Is it by agreement? All right. That may be admitted. Or they may be admitted.
And I would also move to enter as the next exhibit a certified copy of imaging records from the South Shore Hospital for Lindsay Clancy from January 24th.
They may be admitted.
So finally, Dr. McDonough, did this defendant receive surgery at South Shore Hospital?
Not that I'm aware.
Did you observe any cuts, abrasions, or blood on the area of her head?
No.
And based on your review of those findings on the CT scans, was there any noted injury from the head CTs that you could tell?
No.
And were you able, after using that bear hugger device, able to get her her core body temperature back up to normal?
I don't recall.
Did you ever observe those wounds that you observed on her neck or her wrists ever start bleeding actively again?
No.
And nothing further.
Mr. Reddington.
Morning.
So, would you agree with me that when Lindsay was brought into the South Shore Hospital that she was unconscious?
I recall her eyes being open, but she was nonverbal.
Okay. So, as an experienced emergency room doctor, can you tell me when someone's unconscious, what is that? What are the symptomology of it? What does that mean?
Usually means they're completely unresponsive with eyes closed.
Okay. Was she responsive?
Not verbally.
Was she responsive at all?
She was responsive to pain.
So that means that you would do something to cause pain, perhaps the bottom of the foot or whatever it is, to see if they have a reaction.
Correct.
And would you agree with me that when people even have very, very serious brain injuries, that they can respond to pain stimuli?
Sometimes.
Sometimes. So her eyes were open. Were her pupils equal and reactive to light?
I don't recall.
You don't recall. What does it mean with PERL, pupils equal reactive to light? What does that mean?
Exactly what you just said. It means her pupils are equal and reactive to light.
And as a doctor, what does that tell you?
It tells me that there's no significant neurologic injury.
And in this case, you don't recall if her pupils were equal or reactive to light?
I don't.
Okay. And that's when you take the little flashlight sometimes and you put it over the eye and see if there's constriction of the pupil.
Correct.
Did you do additional evaluations of her to see what her neurological function was?
She was pretty quickly intubated from what I recall, so after that it would be difficult to assess her neurologically.
Sure. Was she on any pain medication, if you remember?
Don't remember.
You recall, did she have difficulty being intubated? I mean, would you agree with me that if you're not under some type of medication or sedation or unconscious, it hurts to be intubated, doesn't it?
We wouldn't intubate somebody without first giving them some induction medicines.
Okay. So what would the induction medicines be?
They're not universal.
Well, what
That would depend on the
What are the
case.
induction medicines that you used on Lindsay Clancy?
I don't know. I'd have to refer to my record, and also I wasn't the one who did the intubation.
So she was intubated, had the tube coming out of her mouth, she's laying on the table, and you are continuing an assessment. You were the lead doctor in the emergency room for Lindsay Clancy, right?
I wouldn't say I was the lead. I think the trauma surgeon and I worked together.
Right. Her temperature, her core body temperature was 82 degrees, is that right?
If that's what the record states, then yes.
I'm sorry?
If that's what her medical record states, then
Well,
yes.
as you sit here, you don't know what her core body temperature was?
I saw her 3 years ago. I see about 200 patients.
I'm sure you're very busy, but this is a murder trial, doctor. Did you review your records and your notes?
I'm happy to look at my record if you bring it
Did
here.
you review your records and notes before you came in here today to testify on this case?
Sir, I did, but I don't have a photographic memory.
Did she regain consciousness at all while she was in your emergency room?
No.
Can you tell me what CSF is?
Cerebrospinal fluid?
Yeah. Is that what that is?
But it
CSF?
could be. I'm not sure in what context you're referring to it.
Well, how about if there's a massive leakage of CSF from her nose? What does that tell you as a doctor?
It could mean that there's a skull fracture.
Did you notice any clear fluid coming from her nose?
I did not.
Is that something you would look for?
Yes.
How quickly do you get the results of the x-rays when you're in the emergency room?
Well, these were CT scans, but fairly quickly in a trauma.
I'm sorry, CT scans, x-rays. So you had CT scans that were able to show you the damage to her neck and upper chest. Is that right?
Yes.
And what did those CT scans show you?
Well, what I remember is a thoracic spine injury.
And when you say a thoracic spine injury, would you agree that top part of your neck, your throat area would be cervical, right?
Correct.
And that's when the numbers go C1, 2, whatever they are. That would be the actual vertebrae in the cervical area of the upper body, correct?
Yes, the cervical spine.
Okay. And then below the cervical spine would be the thoracic spine. Is that correct?
Correct.
And the thoracic spine would be, and sometimes they're delineated as T1, T2, meaning thoracic 1, thoracic 2, all the way down to what, 5 or 6?
12.
I'm sorry?
12.
12. So when you looked at, and the lower portion would be the lumbar. Is that right?
Correct.
Now, when you looked at the CAT scans, did you determine the extent of the injury to the spinal cord?
I could determine the extent of the injury to the bony thoracic spine.
Okay, what was that?
I don't recall exactly the level. I would have to look at the report.
What does that mean, the level of the T?
Correct.
Was her cervical spine injured?
I don't recall. I'd have to look at the report.
Were you aware that her thyroid was crushed?
I don't recall.
Do you know that her cervical spine vertebrae was fractured, destroyed?
I don't recall.
Doesn't that control a person's breathing? Does that have anything to do with breathing?
It can.
What do you remember about looking at the damage to the spinal cord depicted on the CAT scan?
What sticks out most in my mind is her thoracic injury.
Okay, and what was the thoracic injury?
I don't recall the exact level.
What does it mean by effect level?
The exact level.
I'm sorry. Were you aware that there was a complete transection of the spinal cord on T5 and T6?
I'm sure I was aware at the time, yes.
Okay. And just, can you tell me what does it mean when it says a complete transection of the spinal cord at a particular, apparently that would be at thoracic 5 and thoracic 6, right?
Mm-hmm.
What does that mean with a complete transection?
It means the bones are no longer one on top of the other. They're moved apart.
Were you aware that there was a significant edema noted in her chest?
If that's what the report says.
Okay, and what is edema?
Swelling.
And does it also refer to fluid?
It can.
Did it refer to fluid in this case?
I'm not sure. I would have to read the report.
So in addition to the edema that was noted, was there edema noted around C7, T1, T2, T3 to T4?
Again, I would have to have the report in front of me.
When you noted her base temperature as being 82 degrees, what does that tell you as a doctor?
It means that her body temperature is lower than normal.
And what is normal?
98.6.
And if a person goes from 98.6 to 82 degrees before you place her in the bear hugger, what does that tell you? Does that affect the body at all?
Yes, the body works ideally at 98.6. So anything outside of that range is not ideal.
To what effect, as a doctor? What effect, if any, on the body? If a person has an 82 degrees base temperature?
The list of things that could go awry is quite long.
Can you give me an idea, maybe the top 3?
She could have a metabolic derangement.
What's a metabolic derangement?
Meaning her body wouldn't be processing things the way that it was before. Her cells are not working the way that they should because it's too cold.
Would you agree with me that when you were looking at the injuries to the wrist and to the both wrists, actually, you noted lacerations in the volar aspect of the wrist?
Yes.
What is a volar? What does that mean?
It's the anterior aspect.
Interior? Okay, thank you. Would you agree that on both wrists there was deep laceration?
I wouldn't characterize them as deep.
You would not? And when you made reference to her being transferred to a tertiary care center, what does that mean?
It means that it's a hospital that has more services and specialized care than we do at our hospital.
Now, when she was at the South Shore Hospital, counsel asked you about whether or not you noted any injuries to her head. You did not notice any bleeding or scratches or bruises of that nature, right?
Not that I recall.
Did you notice any injuries to her lower body, her legs, her feet, let's say her feet or her buttocks?
I don't recall.
At any time while she was at South Shore Hospital, did she have a cardiac arrest?
Not that I recall.
Do you know she had a cardiac arrest when brought to the Boston Hospital?
Did not know that.
How about blood? Was there any blood transfusion at South Shore Hospital Medical Center?
I don't recall.
Are you aware that she had a massive transfusion of blood once she hit Brigham and Women's?
No.
What does that tell you? Massive transfusion of blood. What does that mean?
I couldn't comment on why they gave it to her.
Were the police in the hospital when she was there with you?
I don't recall.
Was she chained to the bed by handcuffs?
I don't recall.
You redirect.
Previously, Dr. McDonough, I'm just gonna give you your notes, if that's okay.
Sure, thank you.
Just take a look at it and then take your time and just look up anything.
You need
You
this
want
one.
to just flip through the rest of them to see if that's the extent of the note that you got in the records.
Thank you.
Now, counsel asked you on cross-examination about pupils, right? Was there anything notable, according to your now review of the notes, about Lindsay Clancy's pupils?
No.
So what did that tell you about her a possible head injury?
It just indicates that there's no obvious head injury or brain herniation.
Now, you indicated that she was somewhat unresponsive, but her eyes were open. She was nonverbal, correct?
Correct.
Did you observe her to be moving her arms around at various points?
She did move her arms on exam in response to painful stimuli.
And as far as the intubation goes, you're aware that she was in fact sedated in order to maintain intubation.
Again, I'm not certain of that because I was not the one who performed the intubation.
Okay. And you were asked about CSF. Having now kind of looked through your notes with your interaction with this patient, was there any note of cerebral spinal fluid, in either your assessment of them or your review of any of the CT results?
I didn't see any mention of that in my physical exam.
Now, as an emergency department physician, you're not treating all of these spinal injuries, correct?
Correct.
Your focus is to assess, stabilize, and get them where they need to go, right?
Correct.
And so that's what you did with Miss Clancy.
Correct.
When the injuries that were described as a Waller aspect, counsel mentioned that terminology to you, right?
Yes.
You've now, in direct examination, identified those injuries as superficial. What characteristics make you say superficial?
Because I wasn't able to visualize any active bleeding or muscle tissue or injury to tendons.
And is it fair to say that oftentimes patients that come into the emergency department might be, if they have some sort of injury to their spine, you don't want them to move, right?
Correct.
So they might be at some point kind of either put in soft restraints or restricted on the bed.
Correct.
Thank you. Nothing further.
Is there anything further? All right, thank you, Doctor.
Good morning.
Good morning.
Okay, so I wanted to get those two on. And sorry, bear with me here. I wanted to get those two on. I thought it was important to hear about them. And for the last one, I kind of got to agree with the defense. She could have been a little bit more prepared. Let me know what you think. But we will try to get the rest of them up. But like I said, I did want to definitely get the psychiatrist on as well as the ER doctor. So thanks for joining me, and we will talk soon, guys. All right. Bye.